Last week, cases versus theory, but I'm sorry, this week I'm not going to make the same offer. It's just going to be you get what you get. Um, I can talk till the cows come home about lung ultrasound, but in actual fact, I've been given the topic of breast and lung ultrasound. So before I go down any rabbit holes, I'm just going to spend 5 minutes talking about breast ultrasound. In ED, it's not our purview to diagnose breast cancers or suspicious lesions. The most we'll be expected to do will be to assess collections. And of course, the question is going to be, is it a seroma, a hematoma, a galactocele, or an abscess? Yes, we may accidentally come across cancers, and Adrian confirmed this last time I did this talk, that's not really our purview. We may be asked, I guess, to assess a ruptured prosthesis if someone comes in with chest pain that's tender, but that's also fairly rare. And I only have one single picture of prostheses, and I'm afraid it wasn't ruptured. Just so as you're aware, in the same way as we have TIRAD score and ovarian mass scores, we also have a BIRAD score to describe breast lumps, and it goes from 0, which was when you didn't get enough pictures, down to 6, which is a known malignancy. And the only area that we may possibly be called in to look at is this 2-3 group, where we have either blatantly benign entities such as lymph nodes, simple cysts, and definitively benign solid nodules. I'm not even sure I would call one of those. And then there's group 3, BIRADS 3, which is the probably benign, which gets the complex and complicated cyst and solid masses. Now, they're ones that if there was a very good history suggesting of an abscess, I might possibly aspirate, but I would be referring on for dedicated imaging, anything above a 2. A simple cyst is a simple cyst anywhere. It's anechoic, it's very thin-walled, and no follow-up is required, but it has to be pure and simple, like a very simple renal cyst. If the cyst has anything in it, such as content or septations, you do have the option to aspirate if, for example, you're pretty sure it's an abscess by the history or a hematoma by the history. But you can also refer those ones in. There are particular cysts that the specialist sonographers can categorize as benign, but it's to do with does the milk of calcium move and reposition on position change? How compressible is it? These things, I think, are really a very high stakes call, and I don't think I would leave it at my on my ticket. So it's the sort of thing that I'd be referring on. Just for your own interest's sake, if you stumble across one accidentally, cancers are usually hypoechoic with irregular margins and taller rather than wide. So anything other than a simple cyst, I am on referring. I did get this out of Radiopedia because I think it's interesting. What I find it interesting is that these are very similar to the signs of malignancy you have in other parts of the body. So, for example, these sorts of signs are quite similar in your thyroid malignancy, what's the word, estimates as well. So malignancy is usually dense tissue with posterior shadowing rather than the posterior enhancement after fluid. The malignancy usually has spiculated angular margins or extensions into ducts, whereas benign masses are generally ellipsoid with gently curving wide lobulations. The thing that I love that's so typical everywhere is malignancy tends to be taller rather than wide, and the benign lesions are wider rather than tall. Malignancy may well have microcalcifications, may well be heterogeneous or hypoechoic, and is often surrounded by echogenic or inflamed fat that I assume is trying to fight it. Now, breast tissue, when you scan it, even with a linear probe, looks like uh, very indistinct, I think. It's the kindest thing I could say, and I'm female. Um, don't forget we have the skin at the top. Underneath the skin is fat. And then we get this irregular, I wouldn't even call it a layer because it doesn't sit in any single plane, but it's of echogenic ductal tissue, which, pardon me, has its own, I guess you could call them almost spicules or tetherings in the ligaments of Cooper. Anyway, under the breast tissue, we then have the pectoralis muscle, which should be smooth with a linear fibrillar format. Then we have ribs, and then we often have diaphragm. So long as you keep in mind that the breast tissue is the echogenic stuff between the fat on top and the pec muscle underneath. The nipple itself is often normally hypoechoic, but also dense. And as you can see, we expect to see shadowing, and so we have to increase the TGC underneath the nipple. This is normal, and if you have a lactating mother, you'll see all these little ducts leading up to it. This in the middle here is just what breast tissue looks like. Sorry, is that a question anyway? Sorry, I'm
Sorry,
not.
just coughing. I'll mute myself now.
No, it's okay. So this is typical for breast tissue, and it's often described either by the quadrant of the breast that it's in, or it's described in a clock face with the nipple obviously as the center. We have these things called ligaments of Cooper, which are thin and fine. I managed to stop one on the left picture. It looks like a little pointy bit. But as you pan through, these ligaments of Cooper cause sort of linear strikes, a bit like tiger striping that you see in the uterus, but we see it in the breast. And this is not abnormal. This is what you expect from the ligaments of Cooper. Now, something like this, which is ellipsoid, smooth, it actually does have fluid. That's actually fluid, and you can tell it's fluid by the fact that we've got the post-cystic enhancement. No lobulations, no speculations. The stuff in it does actually move with position change. It turned out this one was diagnosed as a benign cyst with milk of calcium in it. But there's very little that I wouldn't be passing on to formal scanning. Just for your interest, this is what a galactocele looks like. I got this off Twitter from Ecotech4. The galactocele is the black bit. But off to the left, you can also see a round isoechoic area that's leading up to the nipple, which they were very concerned about was a ductal, I think, papilloma or carcinoma. That was the suspicious lesion there, the one that has the little question marks inside it. The galactoceles, I gather, are often subareolar when you stop breastfeeding. They're the lumps you see. They may become infected, but not often. If they're not infected, there won't be any vascularity or bright fat around them. This, on the other hand, is actually a breast abscess in a tiny person. And as you can see, the content of the abscess, which was actually thick pus, is isoechoic to the rest of the tissue. If you look really carefully, and I'm aware my screen's glitching, I'm not sure why, but you'll actually see a bit of independent movement just down in the lower left quadrant of this mass. Often unfortunately, you need to press these things to see if they've got independent movement. My one and only images of breast implants, and I wasn't actually aiming for the breast implants, I was aiming for the pneumonia underneath it. That hypoechoic area off to the side is the breast implant, and it often impairs the throughput of the sound waves, so you often can't see deep to it. They're a right nuisance, but you probably won't miss them. I'm sorry I don't have any pictures of ruptured implants. I do have one case, just because I felt we should. A middle-aged woman with a firm non-tender lump behind the left nipple. History of breast surgery 4 weeks prior, no history of breast cancer. What's your differential diagnosis? Andy, can you start it off for us?
Yeah, so the differential would be a postoperative seroma,
Yep,
which could be infected, leading to an abscess
yep,
formation.
yep.
Could be a hematoma if there is bleeding inside
Mm-hmm.
the lump
Yep.
postoperatively. It could be something incidental like a fibroadenoma or a carcinoma, less likely that's just not been detected until now.
Excellent. Okay, Dion, I'll show you the pictures. That's a pan view in long. Trans. Long. This is not a hard one, by the way. It's not meant to be tricky. It's just giving you a practice. Like I said last week, they'll always give you an easy case at the beginning of the Vivas that you have to be able to spit off your answers automatically. And that's our pan through. Okay. Dion, what do you think?
I think it's suggested for a breast abscess.
Mm-hmm. Okay,
A lot
what's
of
your evidence?
surrounding inflammatory changes, it's really echogenic breast tissue, um, with some with some vascularity surrounding the tissue. This sort of really altered ecotexture of the tissue, loss of normal ecotexture of the breast. Yeah, suggested for for an inflammatory process, and then there's anechoic fluid with echogenic foci within. I didn't think video if there was some, if you could see there was some
Yeah,
dependence.
yeah, yeah.
Yeah. And the soft tissue, the dermis and the subdermis, there's some altered ecotexture as well. It looks like it is very superficial. You wonder if it would drain with
Mm,
pressure.
yeah. It's actually coming up very close to the subareolar tissue there. Now, don't forget in the exam, if you've got something with measurements, you've got to pounce on the measurements. So here we've got nearly 3.6 centimeters by 1.6 by 2.7. I don't expect you to calculate a volume, but it's good to be able to say it's about 3 by 3 by 2 centimeters. Ben, if you were trying to calculate a volume, would you try and calculate a volume of this?
I feel like there is an equation out there like 0.4 times those three measurements, but I would probably just tell them the measurements and the depth from the skin, and more about whether it's septated or not to describe it to a plastic surgeon.
I think you're wise. There's certainly a volume calculation, which I think is overused. It's length by breadth by height by 0.52, but that only actually refers to an ellipsoid, and yet you see the sonographers doing these measurements on such an irregular shape as this, and then multiplying it by 0.52 and coming up with a volume which I think is extremely misleading. So that was a trick question. I was hoping you'd say, no, I won't do a volume, and you pretty much did. So you did that
I
one
did.
nicely.
I find the machine often gives you one, and it's
Yes,
tempting to use it.
yes, I know. Yeah, just as an offside, you realize that there are at least 3 different formulas for bladder volumes depending on the shape of the bladder, whether it's rectangular, football shaped, or something else, triangular. But anyway, we're not talking about that. I think you'd win either way, particularly if you said it's in irregular shape. Now, Dion, good description of it. I think that the echogenic enhancement around it is probably more to do with post-cystic enhancement. We've got to ask ourselves, is there actually echogenic tissue beside it? as well. And this area here, this is actually just near the nipple, so it's not as abnormal as you might think, where all the ducts coalesce up under the nipple. Here, yeah, that's pretty much all mass. Anyway, I'm not so sure. I think it was probably a seroma, but I didn't end up aspirating it. It went on elsewhere. I think you answered that well, though. You
Can I ask a quick
got the
question?
right things.
Just
Yeah,
because I've
yeah.
actually never seen anyone aspirate a breast mass. Presumably, if it's an abscess, you need quite a wide bore needle. What sort of size needle do
Yep.
we generally use for breast abscess aspiration?
Well, me, once or twice I've done it. I've done it with the 18 gauge after some local anesthetic. When we're pretty sure it's a seroma, though, it can be the smaller gauge because the seroma tends to have the thin fluid in it. It's something that radiology department does not infrequently in the post-op patients. They have a list of collections to aspirate after breast surgery. And they're quite irregular things. They won't be nice and round like a sebaceous cyst or something.
All right, thanks.
Okay, now the last 3/4 of our time is going to be dedicated to lung. I'm going to assume that you already know the basics. Would that be right? You know what B lines are and consolidation and effusions look like? Am I right? Yeah, okay. What I want to do is actually look at finessing your interpretation of these signs. The reason, before we do that, these are 3 references. The top one is a large monograph which you can download free of charge from the European Respiratory Society, so long as you give them your name and your date of birth, that sort of thing. And you wouldn't study it for the exam, but you could keep it as a reference because it's really complete. The second one by Dr. Mark Hugh is actually, he's a respiratory physician in Australia. It's a really nice article that talks about the limitations of lung ultrasound, what steps you can't take. And the last one, chest sonography, is sort of the Bible, and it costs about $200. And I would not recommend you download it unless you actually want to do some research. But the first 2 are a lot more accessible. Now, pardon me, has anyone had any real problems with lung ultrasound so far? You ever been led up the garden path, anyone? Andy, yes or no?
Yeah, I mean, sometimes things are always challenging, aren't they? I think pleural effusions are nice and easy to spot. Sometimes lung sliding can be challenging in those more complex patients or intubated patients, things like that.
Dion, what's your experience?
I've attempted to try to do some research with lung ultrasound in terms of in drowning because I have a lot. It's very hard because
I
it's so
remember.
because it is so diverse, and the etiology, it's so much clinical, and it's very hard to standardize the exam.
Yeah. And I
So
don't think you're going to get enough patients either.
yeah.
Yeah, I remember we talked about that. Ben, what's your experience with lung ultrasound?
Pretty good. I don't think I've been led up the garden path too much. I did get tricked recently by a breast implant that I thought initially was a pleural effusion, but luckily I'd realised before I had to go back on what I'd said to the patient initially. And I had another recent one recently that had really, really bright echogenic pleura, and it looked like it was having loads of B lines, but I suspect there was something else going on in the pleura, but we never really found out. But I don't think the lungs were particularly wet anyway. But no, I think it's really good.
Okay, well, my plan was to look at what to do with these signs because they're very sensitive. We see them all the time, but they're not specific. They're a bit like D-dimers and high sensitivity troponins, and what we're finding is we have to reset our expectations of normal. What I want to do is spend a bit of time looking at sliding, because you're dead right. It is really hard to call in your difficult patients, in your respiratory ward patients. Sliding, to my mind, is actually the hardest of signs. B-lines, I want to look a little bit more at B-lines because they sort of took off in importance and interest during COVID. And of course, once we had a lot of more people with COVID, then you couldn't just say 12 B-lines equals pulmonary edema. It didn't work anymore. There are some tricks you can play when you find a consolidation to decide what sort of consolidation it is, but you'll probably only narrow your differential from 5 to 2. You just still can't get it completely down to 1. And a quick look at effusions as well, or pleural thickening. Now, I'm assuming you're all familiar with sliding, which is really nice when the patient's not short of breath and not heaving and breathing quickly, and it can be quite easy to see. And if you see sliding like this, then you're happy. You can say, there's no pneumothorax at this point where I've got the probe. Now, it can be very hard to look, for example, in the apices of the lung. But if you're chasing a small pneumothorax, you can turn the patient upside down, you can lie them on their side, you can move the highest point of the chest to somewhere where you can scan it. Not sure why my computer's glitching on the clips at the moment. B-lines, yeah, there are things that cause huge animosity over in Europe, because the different groups in different countries want their own diagnosis made free. Consolidation, when you see something like this, you've got to ask yourself, is it pneumonia? Is it atelectasis? Is it a malignancy? Is it a hemorrhage or an infarct? And we can pull it down a little bit. So I'm going to give you 3 cases. The first case is a sliding case. The second case is a B-lines case. And the third case is going to be a consolidations case. And we're going to work through them with a few more tricks. So when you haven't got sliding, what's the differential diagnosis of a piece of lung that doesn't slide? Andy, give me one. Anyone?
Pneumothorax.
Good. Yeah, that's easy. Okay, Dion, what's another cause of no sliding?
Not breathing, apnea, not being bagged.
Yes, you're correct. Okay, Ben, what's another one?
So what was Andy? Sorry, pneumothorax, cardiorespiratory arrest. I'll go pleurodesis.
Pleurodesis, excellent. Anything else, Andy?
If you have pleural problems such as asbestosis, could that affect your pleural sliding, or mesothelioma?
It does actually, yes. Yes, good call. And there's one more.
Pulmonary fibrosis?
Nope,
Nope.
you can normally see that one. It's actually bulla. Bulla can be so hyperexpanded you don't actually notice any relative sliding, but there's ways to get around it. So pneumothorax, bulla, pleurodesis, they're our main ones. Mesothelioma, you're quite correct, doesn't slide, but it usually has a very characteristic surface, and I'll show that later on. The best tip I can give you when you have a non-sliding picture is to look up the prior imaging and to take a history, because your patients without sliding are almost always your chronic respiratory patients. They're the ones who've had things wrong with them in the past. So it can be, as you said, extremely hard to detect. Dion, up to you. Do you think there's sliding in this image?
Is there also a vertical artifact? If so, then there is sliding. So that's what I think.
This is a horrible picture. Can you see how the vertical artifact is actually moving apart like this?
Yeah.
Yeah. It's not a true vertical artifact, I hate to say it. This is
Yeah.
extra strong A lines. In actual fact, the pleural surface is really, really, really shallow. It's not the brightest line. The The brightest interface is actually the first A line. This patient has dreadful emphysema, so no subcutaneous tissue. I have no idea if this is sliding or not, but I put it up just to show you how hard it can be to pick sliding. That's actually the ribs there, and that's the pleural surface there. What about this one? Is this one sliding? Who are we up to? I've forgotten.
No,
No, but do you think it's a pneumothorax?
no.
Good, why not?
Because you can see the irregular pleural surface markings,
Excellent. Yeah,
which must be the visceral pleura.
exactly. So probably pleurodesis in this case. Okay, Andy, back to you. What's this one? This is region 4 in a trauma patient who's supine.
So it looks like there's pleural fluid, which would be probably a hemothorax, and then you can see the lung sliding coming in and out, which makes me think it might be a hemopneumothorax.
Good and bad. Good and bad. Now,
Or just a hemothorax, sorry.
no, you're right. Don't go
Yeah.
back. You're right. It's a hemopneumothorax. But the area that you've talked about as sliding, I want you to look at it really closely. And I'm aware that my clip is not running very well. It's got a beeline in it, hasn't it?
It does, yeah.
But it's coming from the patient's feet. If you think about this
Okay.
patient
Sure.
head on the screen left,
Yeah.
look,
Maybe if they got free abdominal air or something.
well, it's probably hemopneumothorax, as you said. And James Rippey, when I showed him this in desperation, said he thought that the beelines were probably due to tiny little bubbles in the fluid. So if you look at them too, they're actually not actually sliding. It's more like your abdominal free gas where you press down on it and then you pull the probe back up again and the air comes back in the picture. So it's not true sliding, but I think the quality of the image is probably not good enough to show that. So this is my unstable breathless patient who's sitting up. The treating team have asked me to see if there's a loculated pneumothorax. They're not sure whether they should do an urgent thoracostomy. She's too sick to lie down and go for a CT. So I looked at that and said, oh, easy, I can do that. Of course, famous last words. Obviously, you can see from the shape of her, she's got known bullous lung disease. Now, whoops, sorry. There are what I would call 5 get out of jail cards for this particular problem. We'll go through each of them. The first thing I tell people to do, and this is not the case, this is a different case, is to actually look at the sides of the image, not the center. We spend all our time looking at the center, but the center of the image is horizontal, perpendicular to the probe. We're not actually going to see tiny bits of movement. So there is a reason that we talk about marching ants heading just under the ribs, because that's where we tend to see movement more accurately than directly under the probe. Hang on a tick, and I need that. Okay, so first thing, look at the edges and under the, just as the pleural goes under the rib. There. In this particular case, another clever trick is to turn the probe so that the pleura is no longer horizontal. It is easier to see movement when the pleura is at a slight angle. What do you think about this one? Is it sliding? Oh, hi, Jenny. How are you? Do you think there's sliding here? This is that patient. Dion, your call?
I find it very difficult. Super lateral, maybe there is some sliding.
Whether there is sliding or not, Ben, what's the get out of jail card on this particular image? You had it before.
What's the question? Sorry, why is there no sliding, or what? How do you know it's not pneumothorax?
How do you know it's not a pneumothorax?
So again, you can see below the pleural line. So you can see like a little loculated effusion or consolidation or something there, which means there must be no air between the pleurae.
That's right. So there's no pneumothorax, but I don't think it's sliding. I think this is an area of pleurodesis where the lung is stuck.
Is there a lung pulse, or is this just your clip ending?
I think it might be a lung pulse, actually.
Yeah.
Noticing that too. Get out of jail card number 3. First one was look at the edges. The second one was rock the probe a bit. The third one, of course, is self-evident. Go down to a linear probe. This is the same patient. Jenny, are you happy to answer questions or?
Yeah, I'm happy to answer questions, but I'll give it a shot. But my knowledge is probably not as good as the other guys.
I was just asking about this one. It's the same case. Do you think that this clip shows sliding?
Tricky to say. Maybe.
That would. No, yeah, well, no. I think
feel like
that's the
there's
correct
maybe.
answer. Maybe. But the second part of the question, even if we can't see sliding, do you think this clip demonstrates a pneumothorax?
I wouldn't say so exactly. I probably will try and get more views or have a look at more different zones of the lung.
Well, that's what most of these pictures have been. But there is one thing in this clip that shows you it's not a pneumothorax, and that's this tiny little pleural line irregularity that comes in and out of the picture. Now, as Ben mentioned earlier, these tiny little irregularities on the surface, even though they're less than a millimeter, they still prove to you that there is lung tissue here. Because you had complete pneumothorax, you wouldn't get even those tiny little irregularities. That's why it's so good to go down to a linear probe. In this particular case, right in the apex where that bulla appeared to be worse, we had this pattern. And I think what this is showing is chronic pleurodesis that's very patchy. Bits of the lung stuck and bits of the lung not quite stuck. We've got bone here. Can't remember what bone that was. Now, of course, if you've got time or a really bored medical student, you can send them to drive around every rib space with the linear probe and try and find a lung point like this. Lung point, what are the test characteristics of lung point? Does anybody know? Or I don't need an exact figure, but is it sensitive or is it specific or is it both?
I think it's pretty specific, but not.
That's right. Yes.
sensitive. Yeah.
And exactly. It's very specific. They say it's the only thing that's 100% specific in lung ultrasound. But why is it not sensitive?
As you just say, that it is very hard to be really complete in your exam and to assess all the regions. And there's some regions that you maybe they're hidden, they're hard behind the scapular region. There are areas of the lung that you cannot sonographically interrogate that well.
Yeah, okay. And then there's another cause for its non-sensitivity. Any other thoughts? If you have a completely collapsed lung, you won't have any lung tissue on the surface to cause a lung point. But as I said, if you can find one, it's good value. Lung pulse. What do you think about lung pulse? Ben, what's the relevance of lung pulse?
Once again, it shows that there is no pneumothorax because there's transmitted cardiac pulsations going through to the pleural surface.
Excellent.
Even when they're not breathing.
Do you find it useful?
I find it very hard to show people. So
Yeah.
no, I don't think I've ever used it.
I don't think it's useful either because the majority of people are short of breath. And well, here we go. That was this patient. This is this patient. What do you think? Is that a lung pulse?
I mean, normally the lung, I suppose it would depend on the speed of the cardiac pulsations, but that could be lung pulse. It could be movement of the probe if you're not moving it properly, or CPR or something else that's causing it. But
Yeah.
probably does mean that there's no pneumothorax. Although even the barcode side of things is pretty. It looks like the pulsations continue up above the pleural surface as well. So
Yes, that's it. That's the problem with it. The pulsations continue above the pleural line. And that's probably the intercostal muscle heave, people going like this. There's another reason I find M mode not much use in lung ultrasound. So I called this one not useful. I couldn't tell if it was lung pulse or not.
Yeah.
B lines, what do B lines mean? Like this. Oh, I've got the answer there, sorry. Tethered B lines or still B lines essentially mean a bit of lung pleurodesed at the spot. Doesn't tell you about the spot to either side. They're a bit of a scary thing, a bit of a Halloween pumpkin type thing, tethered B lines.
I thought a beeline had to start the pleural surface.
It
Is that-
does, it's at the pleural surface, but it doesn't tell you whether you've got pleura to each side of it. You can have just a shred of lung sticking up to the pleural surface. It only tells you right about the bit of lung immediately causing the beeline. I'll show you the pictures shortly. But really, I think, and in retrospect, I didn't do this. I should have done this. It took me years to work out what I should have done. To see if this patient was genuinely about to arrest, I should have actually scanned the heart and the IVC instead. And this is a different patient. It's the only real example I've got of a big IVC and a small right ventricle. So a non-collapsing IVC and a small right ventricle, suggesting what? Jen, do you know what this suggests?
I mean, the dilated IVC means they're quite fluid overloaded or maybe a significant pericardial effusion or tamponade.
But a small right
Small right ventricle.
with no pericardial effusion. Dion, can you help out?
Yeah, if it's tensioning in terms of air outside the right ventricle can completely get compressed from the outside. IVC.
Is that the mechanism, Ben? Do you know?
I was nodding away because that sounded really good to me. I don't know what's going on.
Look, I might be talking through my hat. This was what we learnt last century. But back in the old days when we were doing our primary survey of the trauma patient, we had to look for distended jugular veins because they were a sign of tamponade or tension pneumothorax. And what we were taught back then was that there was a degree of mediastinal torsion where the heart got pushed to the side and the IVC couldn't get into the right ventricle. I don't know what it's called these days. In those days, it was called mediastinal torsion, and we were told that was the reason people arrested with a tension pneumothorax. And so that's what you can look for or that's what I should have looked for in this particular case, because they were telling me this patient's about to arrest. It's not the lung you should be looking at. It's probably the heart and the IVC. This is another nearly tensioning pneumothorax in another patient, but as you can see, you can just barely see that right ventricle is fairly empty. In any case, I do have another picture for you of a low pressure tamponade, another mediastinal torsion, where it's actually the pleural effusion with the tension hydrothorax that's causing the low volume to enter the right ventricle. So that right ventricle is collapsing. It's collapsing like it would with a tamponade, but it's not actually a pericardial tamponade. It's caused by the tension hydrothorax on the left of the screen. I don't think I've got the IVC from that one, unfortunately. Oh, yeah, I do. There we go. That's the IVC not collapsing on that one. Not my best of pictures. Anyway, back to our case. This particular patient, it was a long time ago. I couldn't figure out what was going on. I just put my hand back and said, no, I'm sorry, this is too hard. I don't know what's going on here. She eventually just got better in a few hours later and did manage to get a CT scan, which was reported as cystic lung disease, no pneumothorax. But this is what it looked like. Yeah, and I think, so according to the radiologist, whom I have the greatest respect, this was still lung tissue or bulla. So I'm quite glad I didn't put any tube in this woman. So remember, if you have doubts about sliding, rock the probe and look to the edges of it. Double down to a linear probe and see if you can find any tiny pleural-line irregularities. If you've got time, look for a lung point, but it's not something I do myself much. If you've got a definite lung pulse, that's good, but in all chances you won't actually get a good lung pulse. My bottom line is, if you're really concerned about this patient being in danger of an arrest, it's not the lungs you should be looking at, it's the heart and the IVC, the right ventricle and the IVC. Any questions on the sliding question? Or comments? Anything is welcome. Oh, it doesn't look good. Prefer questions. When is a beeline not a beeline? In the very beginning, they used to have different names. They called them rockets and comets and lasers and beelines. Back in 2010, they tried to have a consensus where everyone got together and they came up with a definition. The beeline was a discrete laser-like hyperechoic reverberation artifact from the pleural line extending to the bottom of the screen without fading, moving synchronously with the pleura. Now that definition's lasted a fair while, but with the newer machines, the beelines sometimes get filtered out and you have to reset them. I think with the stitching algorithms of these multi-focus machines, I think they don't carry the beelines on very well. And so these day and age, I'm happy if the beeline goes at least halfway down the screen. I think in the interim, Gino Soldati tried to separate them out and talked about wet beelines as in pulmonary edema or dry beelines as in inflammatory change. And I quite like that definition, but Liechtenstein from France wanted it all to be his way. The Italians had a lot of experience in COVID, and the Germans have been doing lung ultrasound quietly for 20 years. They did try and do another consensus guideline 2022. However, it had very few people in it that were in the original workplace. They really, there was only a few that were in the original consensus guideline. They did introduce the physicist, Dr. Miller, who's looking into harms of lung ultrasound. And I don't think they invited Liechtenstein along because they want to rename beelines as vertical artifacts because they say that they are so dependent on frequency, bandwidth, depth of chest. Okay, bye-bye case. The latest theory is, I think, called the acoustic trap, where all these different parts are actually involved in the creation of the beeline. So they're talking about a void or a space between the air cells, and the dimensions of the space between the air cells is important. The length of the little channel that reaches the space is important. The wavelength is important. And all these things combine together to show us the B lines. And what they're telling us essentially is that Liechtenstein just struck it lucky when his particular Hitachi machine just happened to show the B lines in congestive cardiac failure. The good news about this is that they think in the future, perhaps with AI, that they'll be able to tell us more about what sort of B line it is by what frequency at which it is maximal. So they're going to use adjustments in the ultrasound machine to try and closer define the characteristics of these little acoustic traps that cause the B lines. Now, certainly B lines are more distinct. You'll see more of them if you have the focus right up at the pleura. This is the same place. On the middle one with the deep focus, we just see one B line that sort of spreads out. And the cardiac case, even with a cardiac setting, you can actually see B lines quite well, probably more. I actually use the cardiac probe for my obese patients because they are very hard to image. But the real kicker is whether the B line is associated with pleural line abnormalities. The theory being that pulmonary edema is not associated with pleural line abnormalities, whereas dry B lines or inflammation are. And for a while we thought, yep, okay, that was good. That's how we could tell whether the patient had pneumonitis versus pulmonary edema. Nearly worked, and then COVID came along. Another thing that the consensus guidelines decided to do was talk about subpleural consolidations, pleural line abnormalities with subpleural consolidations. Liechtenstein called this all C patterns, but the consensus guidelines said, no, that's not enough syllables in the world. We need to call them pleural line abnormalities with subpleural consolidations. Anything smaller than 1 centimeter was what Liechtenstein said, and with COVID, they've decided to subpleural consolidations probably less than 1.5 centimeters. My personal definition of pleural line irregularities is something that you can see with the curved probe. Because honestly, if you put a linear probe on just about anyone's lung, you will start to see small pleural line irregularities. These micro pleural line irregularities are of interest to the rheumatologists for their connective tissue disease, but I think they're probably a bit small for us in emergency. There is a new consensus guidelines in the process at present, but it's going that slowly. I'm a bit worried that it will never come to fruition. Anyway, this is case 2. This is a middle-aged patient who's been breathless for 3 days.
I didn't see anything. First she admits it, now it's a legal requirement. When someone asks you a question,
I didn't see anything.
I wasn't there, and if I was asleep.
Does anyone tell me what we're listening
It has
to?
a recording of it, that she saw it.
Min, I think you need to mute yourself.
I mean, I can just tell you.
Yeah, but you can just say,
Was there questions to me?
Sorry.
I know. Case 2, middle-aged patient, breathless with a fever for 3 days, not improved with antibiotics, but then not improved with diuretics or CPAP either. And this was a long time before COVID. This patient had essentially B lines everywhere, but no effusions and no consolidations. So what's our differential diagnosis of diffuse B lines in every zone? Jenny, can you give me one answer? Anything at all, simple.
Pneumonitis, like a viral
Yep.
pneumonitis.
Beautiful, you can have that one. I was going for something even more simple than that. Dion, what's yours? Diffuse B lines?
A good lung injury, ARDS, yeah.
Or drowning, yeah. Benjamin?
Fibrosis, pulmonary
Yes.
fibrosis.
And what's the easy one? The really easy one? Min, are you joining in or just watching? I mean, the really easy one is pulmonary edema. But yes, you're dead right. Pneumonitis, acute lung injury, fibrosis, we have to be able to tell them apart. So the patient had this sort of picture. This is zone 1 on our top left, zone 2 on our top right, zone 3 down on the left base, zone 4 on our right base. But I always myself put the diaphragm in with a bit of liver or spleen to the right, so that's not consolidation. And looking at this, I could not tell what sort of condition this was. Looking back onto it after a bit of research, it was easier, but essentially the rules, the wet pleura or the pulmonary edema are most usually with a smooth pleura, that's smooth to a curved probe. Lichtenstein always described them as increased sliding, more slidey than not, because he said it's so slippery. There should be a diffuse contiguous distribution. You know, on an ECG, you look for your ST elevation, you're looking for ST elevation in contiguous leads. The same thing happens with pulmonary edema. It should be in contiguous zones. There should be some sort of gravity gradient. If the patient was lying on their left side, they're worse down on the left base. If the patient's been sitting up all day, they're worse down at the bases. They often develop effusions in a day or two. And the B lines should shift pretty soon after position change or after diuretics and positive pressure ventilation. You can see them melt away in 20 minutes or so, if they're pulmonary edema. On the other hand, if they are inflammatory, pneumonitis, fibrosis, we should have a thickened irregular pleura, and those tiny B lines are actually starting a millimetre or two beneath the pleural edge. Mostly there is less sliding because the lung is starting to become infiltrated with inflammatory cells of some sort, and it's just not as elastic. These B lines don't shift so quickly when you lie the patient down or start CPAP or diuretics. And most importantly, at least importantly for COVID, they generally have a more patchy distribution. Now, fibrosis, unfortunately not. Fibrosis does tend to be a very even gradient of B lines, but any of your viral pneumonitis, that's been one of the hallmark features, as these areas of normality, A lines, right beside areas of B lines. So you get A lines, B lines, A lines, B lines. We call them spared areas or skip areas. And so if you think about that, what we have is we have two conditions that are pretty evenly distributed through the lungs, but the pulmonary edema should have the smooth surface and the chronic fibrosis should have the rough surface. Of the other two, the acute pneumonitis and the physical insults, they tended to be patchy or centered around the areas of worse injury. Particularly with COVID, it was posterobasal. The trouble with this sort of, it sounds an easy way to split off these B lines, but unfortunately, the better our probes, the more pleural line abnormalities we're starting to see, even in pulmonary edema. And so it's a bit like we now have high sensitivity troponins. We're not sure what the cutoff should be for pleural line abnormalities. It's also possible to invent pleural line abnormalities if your probe's not perfectly perpendicular to the surface. If you fan one way or the other, you can make that pleural line look thick, easy as pie. So going back to this case, where we're just going down the right lung, would anyone like to hazard a guess, thinking about the things that I've just listed, as to whether this was pulmonary edema or something else?
Based on the appearance, it looks like pulmonary edema, given that it's smooth.
It certainly does. It's smooth, but there's more.
Oh.
What else?
There, there seems to be anechoic accumulation in the posterolateral region, which may suggest queer pleural effusion.
You might have missed my earlier slide. I said that I always put a bit of liver there, and that's diaphragm. But good pick. But I did mention earlier that that's actually liver. But have a look at this one here, zone 3. Is there any one of those signs that sort of is very well demonstrated in this axillolateral view?
Is there, there's a lot of confluence B lines on the lateral aspect, but then in the middle zone, less so. Is that even an A line there?
Yes, yes,
Yeah.
exactly, Dion. Do you remember what the COVID guys used to call this? For a
No.
while, they were trying to coin the phrase light bulb or waterfall sign, where you have confluent B lines interspersed with spared areas. Honestly, I didn't know this back then. Oh, there's my diaphragm. Sorry about that, Min. I didn't realize it was there. But I, again, cheated and used my red get out of jail card and looked at the heart. Do you think this is the sort of heart that would be consistent with pulmonary edema? No. This was actually a viral pneumonitis. It was H1N1 back pre-COVID. And again, as I tell my registrars, with B-lines, if you can just do the B-lines, you might be able to bet the car on it. But if you want to bet the house, you've got to do your heart and your IVC as well. And even then, you've got to leave room to wiggle out. Now, one of the hardest questions we're ever asked is, what about the person who has both dry B lines and wet B lines? Can you tell if a patient with fibrosing lung disease has got superimposed pulmonary edema? Anyone got any thoughts?
If you actually save your images and this patient comes frequently.
Yeah. I have actually got a couple, of series of patients, You can look at how it changes with position, but long time back there was a paper that suggested that if you found any area of smooth pleura that didn't have B lines on it, it was probably not heart failure. Whereas if you had only wrinkled pleura with the B lines, that was the fibrosis sign. It was a bit complicated, but essentially my take home from the paper was that there are hot zones, hot spots in the chest where if you're going to have pulmonary edema B lines, they will be there. Do you know where the lung hot spots are, anyone? The highest, it has the highest yield for pulmonary edema B lines in all patients.
I'd have thought the posterior zones, basal zones.
You'd have thought, yes. Unfortunately not, believe it or not, because your hyperacute B lines tend to start anterolaterally. And so it's actually zones 2 and 3, just that anterior axillary line area, or perhaps between 1 and 3, that's, Liechtenstein used to call it the hot spot. And if you've got B lines there, well, you've got B lines there, but if you haven't got B lines there, then it's unlikely to be pulmonary edema. Frankly, I think it's too complicated. I will look at the heart because I can. If the heart looks bad with the big left atrium, I'll tell them they've got heart failure, no matter what. Sorry to be so rude about that one, but I think there are times when lung ultrasound just doesn't get you the whole way, and you have to give up and say, no, that question's too hard. Now, how are we going for time, guys? It's an hour now. Do you want to keep going? Yeah, okay. All right. What to do when there's stuff everywhere? This was an elderly patient with hypotension and rapid AF and essentially lung consolidation. What's the differential diagnosis of lung consolidation? Min, have you got any one thing that can cause lung consolidation? Don't care what?
Pneumonia.
Good. Yep. Jenny, what's one?
If there's like malignancy can cause
Yes,
consolidation as well.
definitely. Always have malignancy, definitely. Getting harder, Dion.
An infarct, but
Yes, good.
Yeah.
Have an infarct. Ben, what do you got?
Atelectasis.
Yes. So that's the big four. Pneumonia, atelectasis, malignancy, infarction. Now, atelectasis, unfortunately, has been lumped together, but there's some good work from the German guys who've been looking at this a while. You really should be dividing atelectasis into two quite separate, different pathogenesis. So atelectasis can be obstruction, such as a cancer in the bronchi, or it can be compression from a pleural effusion, and totally different causes and quite different management, somewhat different signs. So here's a consolidation. Does anyone want to tell me, Ben, since I don't want you always to be last, what do you think about this consolidation?
So there's a dense consolidation that's abutting the diaphragm.
Mm-hmm.
That so it looks it's undergone hepatization,
Yep.
and it's got some static air bronchograms
Excellent.
throughout it, and a slight shred sign.
Yes. So what would be your guess as to what this is most likely?
Most likely a pneumonia, bacterial pneumonia, lobar
Excellent.
pneumonia.
Yep. Too right. There's the diaphragm there. It also appears to be stuck to the diaphragm, which is, again, I think a fairly good indicator of inflammatory cytokines in play. Now, dynamic air bronchograms, are you happy that these ones are dynamic in this picture? This clip are supposed to be much more specific for pneumonias. However, static air bronchograms can be seen in just about anything. So if you get a dynamic one, you're pretty safe to say this is pneumonia. But if you get a static one like our last picture, you have to hedge your bets and say, could be pneumonia, could be something else. It's also hard. I think it's quite easy to fake a dynamic air bronchogram simply by moving your hand a bit or the patient breathing. You can give the appearance of the air moving. So where do we go beyond bronchograms? If all we've got is static air bronchograms, what else can we do? Min, any ideas what else we can look for? It's okay to say no. Anyone?
No.
Anyone else know what we can look for?
In pneumonia,
Yeah.
vascularity, or
Yes.
the presence of it.
What's the vascularity like in pneumonia?
Well, it's present as opposed to a pulmonary infarct.
Yep, good. It's actually increased, probably from all the cytokines causing vasodilation. We can also look outside the lung ultrasound. Actually, I would start with the chest x-ray to see if what we're looking at has retracted or expanded. Atelectasis, by definition, is a loss of volume, so you would expect the mediastinum to shift towards the atelectasis, whereas pneumonia more tends to be volume neutral. Malignancies are often volume positive, and they'll push the mediastinum away from the mass. And so looking at the chest x-ray, first of all, can be very handy. Secondly, you look at the diaphragms with your ultrasound or on the chest x-ray, and if you see one of those inverted diaphragms, we know that whatever's in that side of the lung is under increased pressure. I think inflammation is very important. If you see any floaty bits in the effusion, if you see sticky bits like tethering or loculations, you can be pretty sure that you have an inflammatory process, although a malignancy is not entirely ruled out. The deep margins, now Ben mentioned the shred sign earlier, the deep margins are pretty important, so take time to describe the deep margin. And the vascularity. Now, there is a very little bit of work, not much, on actually getting the resistive index of these, the vascularity. As I said before, a pneumonia has increased vascularity. The Germans call it ramification, whereas there's this really bright tree of blood vessels coming up from the base. The only problem being if you've got an area of necrosis in the middle. The problem with this is that atelectasis also causes the same thing. So you don't get, unfortunately, vasoconstriction. Your atelectasis has just as much vascularity as your pneumonia. The only difference they think that anyone has been able to find is that there seems to be a little bit more vasodilation in the pneumonias, they think, because of the cytokines. So the resistive index is probably lower in the pneumonias compared to the atelectasis. However, I can never get the patient to hold their breath long enough to do a resistive index, or not much. So again, if we look at these two whiteouts, we can see the whiteout on our left is causing a mass effect away from the whiteout. The mediastinum's moving to the patient's right. So we think this is a condition that's increasing in volume, whereas the pattern on our screen right has the mediastinum moving into the left. So the pattern on our left is some sort of atelectatic process, whether it's primary atelectasis or secondary to an obstructing lesion. The pressure increase is really important because this can be quite lethal in patients with that tamponade type physiology. If ever you see a diaphragm that's inverted, I guess it's an ultrasound version of a deep sulcus sign. This is a sign that that patient may actually go into a tamponade type physiology. And is almost always due to malignancy. In fact, I think every case I've read has been due to malignancy. Now, this one here is actually named by the Germans as the pointed hat sign, and it's the classical, sorry about the imaging, don't know what it is, classical compression atelectasis, the atelectasis due to pulmonary effusion. And that's where you get just that tiny, thin, very mobile tongue of tissue with a shred sign deep to it. Can be bigger or smaller. And it's, as you can see, it's loss of volume and the lung has shriveled down. There's no air in it. It's just collapsed fibrous tissue, I suppose. I mean, lung infrastructure, lung matrix. Atelectasis, true atelectasis is usually very mobile. If you think about pneumonias, the hallmark of pneumonias is you get inflammatory cells invading this area. So they take up the space where the air's gone. So your pneumonias tend to be thicker and gluggier and less mobile, but your pure atelectasis will be really limber and moves like seaweed. Fluid bronchograms are a rare find, but supposed to be due to upstream obstruction. The fluid bronchograms are the dark coloured anechoic coloration of the bronchi. As I said before, look for floaty bits and sticky bits, or tethering of bits of lung, because that tells you that there's some inflammatory process happening. And always when you have a nice effusion, enjoy it. Play with the gain, put the gain up, put the gain down, see if there's any plankton sign of moving cells within the effusion. Now, you cannot on ultrasound differentiate transudates and exudates purely based on echogenic material. However, your completely anechoic effusion is probably a transudate, and your effusion that has floaty bits is most probably an exudate. You just can't bet the house on it, this particular one. And the deep margins, this sort of shred sign of irregular fluffy white cloud is most commonly with your bacteria. And it has a sort of a convex upwards pattern, shred sign. Now, who was it that mentioned earlier? I think it was Andy, the mesothelioma. The mesothelioma does stop sliding. It's surprisingly anechoic, but you'll see it's causing pressure. It's actually this slip of anechoic stuff is actually causing the intercostal muscles to bow outwards. And the deep margin, instead of being that fluffy white cloud, is chewed out with sort of concave upward pattern. If you put an M mode through this, you'd actually realize that that lung there isn't actually able to expand or contract underneath that mesothelioma. You only got to see a couple of these and you start to pick them fairly easily. This is what a pleural plaque looks like before it turns into a mesothelioma. It's just a tiny strip of anechoic area. It looks like a sort of a loculated pleural effusion, or looks like a pleural bleb. Sorry about the machine. So if you see these spotted around the chest, you can say this patient's probably got asbestosis or pleural plaques. Here's another one. Here. That one's just near a fissure. Last but not least,
It kind of looked like a little loculated effusion. So
It
hard to
does.
tell the difference.
It does. No, can't tell the difference.
Oh.
You may look, these little plaques can be either visceral pleura or parietal pleura, and how the lung moves underneath it may help. But no, you can't tell the difference. I think these are actually more common than your true subpleural effusions. Now here is one where we actually have, if you look on the little thumbnail, you'll see that the ribs are actually a long way shallower. There's the rib surface there and rib surface there, rib shadow, and yet the pleura is all this way down, like 3 or 4 centimeters deeper than the ribs. And this whole hypoechoic area here in the chest, in the M mode, is actually mesothelioma again. You'll see that the lung underneath it isn't moving very well. This first echogenic band is barely slipping compared to the mesothelioma, and then there's some movement beneath. There we go. I'll just move it along. See how that lung's not sliding underneath the pleural mass? And I think I've got, oh yeah, that's probably the junction between the visceral pleura and the parietal pleura, I think, just there. And that's mesothelioma there in the picture. Here, on the other hand, is a completely different deep margin. When you see a deep margin like this, it's just like a cannonball lesion, something that's grown and pushed the lung evenly away. That's almost certainly malignancy. And as I said, whenever you find any of these, you put the color flow on, and if you don't, you'll make a fool of yourself at least once, like me. What do you think of this area here at the base of this lung? The man who presents with left-sided chest pain and pre-syncopal. Ben, can you describe this image on the left?
So it's a longitudinal shot through the chest cavity,
Mm-hmm.
and that there's what looks like hepatized lung tissue with fluid surrounding it both above and below, superiorly, inferiorly. I'm
That's
guessing if you're doing,
exactly what I said. Now, what do you think about the color flow image of that?
I can't see any color flow in
Mm.
the tissue itself.
Yeah.
So maybe an infarct.
Yeah, much closer than I got. Any air bronchograms?
No,
Mm,
but you don't necessarily get them if it's totally collapsed.
no. I showed this to my American mates on Twitter and they all got it immediately. They said that's a hematoma, a clot in the lung.
Oh, okay.
Showed anyone who wasn't American, no one outside of America's got it, and I think that's because they see so much trauma. So this is
Interesting.
a patient.
We don't normally see that, though, do we? That's unusual.
No,
But,
no.
I mean,
No, but this is a patient who'd actually ruptured their thoracic aneurysm and it had bled into the left chest and formed a cast of the chest cavity, which is why it looks so much like pneumonia, like it's the shape and it moves just like a bit of atelectatic lung. I mean, that's what I thought it was. I said he's got a left-sided pneumonia until I saw something else. But I put that there to show you that actually putting the color flow on is in fact a very useful thing to do. Yes, an infarct would look like this as well. But that was actually clot. So that very first picture that I got Ben to report, remember he said he thought it was a pneumonia and he was right, and he said he put the color flow on. This is what the color flow looks like on a pneumonia. It's usually quite brisk and increased. But of course the patient's breathing and it's really hard to get these patients to stop breathing because generally they're short of breath.
when you say increase, though, I mean, what are you comparing it to? Because normally we can't really see lung vascularity.
Yes, that is a very good point. Normally we can't see it because there's no consolidation. Increased compared to everything else, I guess. Increased compared to malignancies. Malignancies tend not to have a good vascularity. They tend to have a disorganized peripheral vascularity. Decreased compared to infarcts, which tend to have stunted or no vascularity, and clots, of course. But you did right. We don't really know what it looks like when it's not collapsed, do we? I don't know the answer to that, Ben. I'm just quoting the books without thinking about what I was reading. I have tried to put Doppler waves on some of these to see if I could measure resistive indexes like the one article told me to. I did manage to get one suggestive resistive index of 0.8, which was only a little bit above normal, suggesting it was a pneumonia rather than atelectasis. I mean, looking at it doesn't look like atelectasis, too big. And the funny thing is that this is ostensibly the pulmonary artery, which we would have thought would be a low resistance artery, but apparently it's not in collapse. This is some pneumonias in children. It's really important not to mistake thymus for pneumonia in the really young ones. The thymus tends to have an even white speckling. With pneumonias, we have the branching vessels of branching air bronchograms and fluid bronchograms like this one. And we have the shred sign at the base, whereas thymus has, instead of branching tree-like structures, it has a very even distribution of your echogenic dots, and it doesn't have this fluffy white cloud at the bottom like a shred sign. But if you're paramedian and you can see the heart in the picture and you've got a kid that's less than say 18 months, do consider the thymus. I don't think I've put any thymus pictures in. Sorry, I better do that later. Again, this is a pneumonia in a child, just showing what well, what I've been told, then is increased vascularity. I think that's the references for the one paper that I've found that uses resistive index to try and tell the difference between atelectasis and pneumonia. It's not a big group any either. But in summary, you can reduce your differential from 5 or so to down to 2 if you put on the the color flow. You might not be able to tell a difference between pneumonia and atelectasis, but you might be able to tell a difference between pneumonia and infarct, or between clot and malignancy, for example. Always worthwhile putting on the color flow with a velocity, a scale around about 17, 16. Now, the Germans, as I've said, have been doing this for 20 years longer than us, and they've actually been putting contrast into these little peripheral nodules to try and tell if they're infarcts or malignancies or pneumonias. Not something that we'll be asked about, I wouldn't think, in the DDU exam. But just so as you do understand that contrast in lung ultrasound is the opposite to contrast in systemic ultrasound and systemic vascularity. It's a bit like when you use contrast in the liver, the contrast goes first through the hepatic artery, and then you get a second flush, a delayed flush of contrast through the portal vein, because we have a dual blood supply to the liver. In the lung, we have the opposite happening. If we put the contrast in the vein, it's going to go through the right ventricle into the pulmonary arteries, and it will show up very quickly in the pulmonary arteries. But then there will be a delayed flush from the bronchial arteries when the blood goes round through the left, and then the left sends it up through the bronchial arteries, and you get your delayed flush. So sort of the rules that we learn for contrast in the liver are actually the opposite to the rules that we learn for contrast in the lung. And the Germans have spent quite a bit of time working out how to identify malignancies from the timing of the contrast flush. Not that I think you need to know much about that for the DDU, I just think it's interesting that you need to be aware of more than anything. The case, that chest x-ray that I showed you with the white out of the right lung, this was the right apex by itself and with colour flow. This is zones 2 and 3. 2 being anterior chest, 3 being in the axilla. The naming of the zones is not yet approved by the next consensus guidelines. So in the exam, you'd be better describing as right upper anterior, right lower anterior, right lateral axilla, that sort of thing. Here's the zone 4, as in the base. And the heart.
When you talk about these new guidelines that are coming out, who's doing that? Is it the same people that did that last lot?
No,
other
it's the same
international
people
one?
that did the first lot,
The
not the last
2017
lot.
one or the 2010 one?
2010 one, yeah. It's WinFocus is guiding it. I'm actually on one of the subdomains myself, but it's very slow progress at the moment. It's because it's going to be much bigger than the original ones. So I find it hard to teach nomenclature at the moment because I'm pretty sure it's going to be changed in the next year or so.
Yeah.
Yeah. Anyways, so in summary, I don't want you just to look at bronchograms of the dynamic or static. I want you to look and see, have we lost volume or gained volume? Have we lost pressure or gained pressure? You know, has the diaphragm risen or is the diaphragm pushed down? Look for signs of inflammation because that's most likely to be pneumonias or malignancies. Look at the deep margins to see if they're concave or convex, chewed out or fluffy white clouds or just cannonballs. And if you have time and you have a big bit, do put on the color flow Doppler, color flow plus or minus pulse wave Doppler, just to start to get your eye. And even though we don't really know what indicates a malignancy, I suspect at the rate that lung ultrasound is continuing and taking off in the next 5 years or so, we probably will be able to tell the difference. And so it's worthwhile, I think, just looking and starting to calibrate your eye with the vascularity. Oh no. Sorry, I forgot those pleural effusions. I'll be very quick. I personally don't think we should be trying to measure the volume of pleural effusions. There are about 4 different calculations, none of which take into account the internal geometry of the lung. So most of our calculations are out by 100 or 200 mils at least. For example, Balix actually uses Pearson's correlation coefficient to justify his calculation. That's the most commonly used. If you actually look at the scattergram of his results, you'll see that the estimates of the pleural effusion are really not very good measures of what the actual effusion was. So my personal private view of effusions is if you only see it in one zone, I call it small. If you see it in 2 adjacent zones, I call it moderate. And if you see it in 3 adjacent zones, I call it large. It is really hard to stop my residents calling an effusion large when it occupies all of their screen because their screen is magnified. So be very careful. People see a lot of black stuff on the screen and they think it's a big effusion, but they forget that the ultrasound magnifies these things for us. Of course, please comment on loculations like this. This is the sort of thing that's going to need thoracocentesis or at least lysis. Watch and see in the effusion if there's any floaty movement which suggests that the effusion is thin. And look specifically at the diaphragm. Thickening on the diaphragm is almost always malignancy. So if you see nodules or lumps on the diaphragm, you can be pretty sure that this is a malignant condition. Another diaphragm lump. Yeah, we'll forget that. And one last thing, it's a subtle thing, but if you look very carefully at the parietal pleura in this view, you'll notice that the parietal pleura itself is thick again. It's hard to find out much about this condition. The Germans do call it a rind or thickening of the parietal pleura, and it seems to be a chronic inflammatory condition. I don't know any more than that. It's only just starting to be written about, I think. And there we've got it again. You can actually see the thickening here of the parietal pleura. That's not lung tissue there. That's a better view. Oh. Do we need to know about diaphragmatic movement? Anyone need to know about this?
Only if it's on the exam.
I doubt it. I don't think there's enough of it yet. People are using diaphragmatic movement to predict weaning. It's a big thing for the next guidelines. Let's skip that. Rib fractures, you know, you don't need that. My summary. Lung signs are sensitive, but they're not specific. It's really critical if you check prior imaging. You assess your pre-test probability. I mean, I think that's what the exam's about. It's all in the STEM. You should have your differential diagnosis in your head before you even look at the images. Look for the secondary signs, and I guess this talk's mostly been about secondary signs. pleural line irregularity if you can't see sliding, or irregular pleura if you see lots of B lines, or all the things that you look at when you've got a consolidation, you're trying to work out is it expanding or collapsing. And when you've looked at these secondary signs, then you recalculate your odds of the condition. I think that's enough from me. Any questions?
Would this talk be appropriate for pediatric, pediatric population, the stuff with
Actually, surprisingly, yes. It's actually quite, what's the word?
Extrapolatable.
Yeah, yes, that sounds good. Yeah. The only thing with pediatric population is that you have to use smaller probes. And the linear probe does weird things to your B lines. So your B lines look a bit different. They don't always go to the bottom of the screen. The neonatologists love this because it's a far better way of imaging their neonates. So the neonatal lung ultrasound's sort of far more accepted than adult lung ultrasound. But yeah, the bottom line is, yes, it works just as well in kids who normally have pristine lungs. And so your differential diagnosis tends to be a lot smaller in kids because they're less likely to have infarcts and they're less likely to have malignancies.
I think Adam O'Brien's wrote a paper as well where he talked about, this is all pre-COVID, of course, but he talked about consolidations that are less than a centimeter or almost always viral, and bigger than a centimeter, always bacterial, which is quite useful in kids.
Oh, yes. And he also was, I don't know if he actually wrote the paper, but he was telling me about it, about how if you're trying to gauge how crook a bronchiolitis kitty is, if you see lung signs such as subpleural consolidations, then that kid's almost certainly going to need admission for their bronchiolitis. Whereas the kid who's got bronchiolitis and still has a smooth pleura usually manages at home. So I'm not sure too many other people have done that. I think James Sung in America has, but yeah, he also looks at that subpleural consolidations and B lines as a viral pneumonitis consolidation bigger than 1.5 centimeters bacterial pneumonia, not necessarily needing admission, but needing antibiotics more likely. Any other comments or questions?
I just had one question going all the way back to the breast section.
Oh no, that's a bit hard for me.
Well, I keep seeing those pictures of what are they called, galactoseals or something. Basically, if you see one of those, you still just saying query malignant and get them a proper scan because they all seem to have internal echoes. All the ones that I've seen.
Okay. One of the things with the galactocele is supposed to be layering of the milk within it. If you turn the gain up and see if you can see a layer, then you move the patient round. Galactoceles also need to be lactating people. I take it you're just doing the lactating ones?
I haven't seen them personally. I'm just talking about what I've read and seen on like the ultrasound cases website.
Yeah. Sorry, what was the question again? Galactoceles?
They sound like they should be something. When you were talking about them, you kind of talk about them as just something that we can spot and say, oh, that's just a benign galactocele. Or is it just if you see something that looks like that, then just get them a scan, get them a formal scan?
I wouldn't even call a galactocele, I don't think. I don't have enough experience with it. If it's not a simple cyst, then I'm getting it another scan. But if the patient, if it's exquisitely tender and red and got increased vascularity around it, I'm more likely to say, I think that's infected. Shall I aspirate it for you? But other than that, yeah, too hard for me. Yeah.
Cool, thank you.
Anyone else? Any other
What have you
questions?
done? Because you described me the mesothelioma and these pleural plaques, and you said, oh, when you're going to look really well, you're going to see more and more of it. Has it changed your practice in terms of like follow-up imaging or ordering CT chests for people that you, yeah?
Pretty much most of the mesotheliomas I've found have already been known, but the pleural plaques, yeah, they do. I do tend to. I ask the patient have you had anyone say, have you got pleural plaques? And if they haven't, I'll either get a chest x-ray or a CT to define the spread of the disease. Something you probably should ask a respiratory physician though, rather than me. Certainly if I see that chewed out deep margin, I'd be getting a CT, no questions at all. But as I said, most of the ones that I've done so far have already been known. Else? I think, Casey, it's time we went home. Is that you? We're looking.
Casey is home.
Oh,
Yeah, I just got home.
okay. I'll stop sharing there if that's okay.
Thanks very much.
Any other questions, guys? Okay. I'm going to go and have dinner. Sorry, Case.
No, thank you.
Okay.
Yeah, thanks very much. That was epic.
Will you hit
Thank you.
the not record button, Casey?
I'm trying.
Thank you very much.
Or if I can work out how to do it. Hang on a moment.
Well, I'm just going to go off and have dinner if you don't mind. See you later.
Thanks
See
a
ya.
lot.
Bye. Thank you.
Yeah.
Bye.
All right. See you, crew. See you next week.
Yeah.